Hello, this is Ed Becker with the Vasculitis Foundation. Today we have a guest, Dr. Aamir Hussain. Aamir is interested in healthcare reform and addressing healthcare disparities through research and advocacy. He's been interviewed by the New York Times, Al Jazeera, and PBS, and his writings have been featured in medical journals and several online outlets. Aamir has been involved with the Vasculitis Foundation and has spoken at both national and local patient meetings. Aamir, thank you very much for doing this presentation. It's certainly one that has a lot of relevance at this time, doesn't it?
Yeah, thanks so much for having me. Thanks for that introduction. I will be talking about some of the big challenges currently in healthcare policy. And given that there's an election going on, there's lots of candidate plans that are being thrown around, I wanted to explain some of the major points about the big policy reforms that are being suggested and get into some of the pros and cons for each of them. So I'll be going through this presentation, and at the end, I'll be happy to take any questions that people have. So here's a background of me, and as Ed described, I'm from Connecticut originally, went to Georgetown for college, then University of Chicago for MD in public policy, and I became interested in learning about the Affordable Care Act. That was around the time I was in undergrad, and it was like being debated in Congress, and I wanted to do medicine, but also learn about policy, so I kind of got more involved, studied government, and then as a medical student, I got a master's in public policy. And I'm interested in dermatology, so I will be starting residency in 2020. So I have no conflicts of interest to disclose. As I mentioned, this is designed to be fact-based and as neutral as possible. I can provide some of my own opinions if people have questions about that, but I'm generally sticking to like the objective data. And I heard this quote from my friend that I really like: agree to disagree without being disagreeable. So reasonable people can disagree on policy, but in general, I think it's important that we assume the best of intentions when we discuss these things. And it's important to come at this discussion from a fact-based and objective basis whenever possible. So as outlined, I'll be just defining some terms that you might hear in insurance and in the debates, discussing some of the big players in policy, like some of the advocacy groups, as well as the contemporary policy discussions. And at the end, we'll do Q&A. So some definitions around health insurance. So a premium is the amount of money you pay each month just to have an active insurance policy. So this might be a couple hundred to a couple $1,000 depending on your policy. But this is just like a membership fee that you have to pay to keep your policy active. A deductible is something that the insurance uses. It's basically a threshold of money that you have to pay before your insurance will start covering things. So for example, you might have a deductible of $1,000. That means you have to pay out of pocket for the first $1,000 of anything. And after you exceed that amount of money, your insurance will start covering things. And the question is, a lot of insurances differ on what out-of-pocket payments will count towards that copay. Sometimes premiums will count for it. So if my membership is $100 a month, and then I'm paying that each month, by the 10th month, I might have hit my $1,000. However, some places don't consider that as part of the deductible, and then you have to pay an additional amount of money. And a copay is the amount of money you pay at the time of a visit. So you go to the doctor, you go to the ER or urgent care, and when you leave, usually they send you a bill for that particular day of service. That's going to be on the lower side, and these almost always count towards deductible for the month or for the year. So these are kind of the terms you're going to hear a lot with regard to health insurance, and it's going to become important later on as a lot of the candidates are suggesting changes to some of these areas. The candidates are proposing changes to these various areas that will have a big impact on patients who have insurance plans. So next, I'm just going to talk about the big existing insurance programs in the US. This is not a comprehensive list. There's actually a lot more options, but these are some of the major ones. So Medicaid. Medicaid is a type of government insurance that's a partnership between the federal and the state governments, and it's administered through the states. And it's designed predominantly for low-income people. However, what's really important is that it is a state-by-state policy. So each state has a different threshold for who qualifies for Medicaid and what services it covers, as well as how much services it's going to cover throughout the whole year. And the problem is when you move to a different state, the laws of Medicaid are very different. So that's one of the kind of barriers to people that move, is that they have to sign up for a different state's policy. Medicare is one of the biggest insurance carriers. I think it covers about a third of the US, depending on how you calculate it. This is a government insurance that is only administered through the federal government. So this is administered in the same way in every single state. The federal government sets the rates for this and what's covered and how much money people pay for it. And this service is given to everybody, all citizens at age 65, for sure. And you can qualify if you're younger than 65 if you meet certain conditions. So disability sometimes qualifies you for Medicare. Certain conditions such as kidney failure can qualify you. So the government will essentially pay basically your taxes are going into this pool of money that the government will use to cover everybody. Next is private insurance. So these are the kind of commercial plans that you hear about. So Blue Cross, Aetna, there's various different combinations of those. And essentially, most people get this through their job. So if I work for a big company, the company buys an insurance plan that covers all the workers. If I work for their company, I get paid a salary, and part of my benefits are also a health insurance. So this was designed back around World War II, when there was wages that were capped. The US was at war, so there's a certain amount of money that was fixed. So employers couldn't give people higher salaries. So the way they got around this was, instead of, for example, giving me a $100 pay raise, they said, you have $100 worth of credits you can use in insurance. So I could get $100 worth of healthcare and rather than just $100 cash. So since that system started around the World War II, that's basically stayed in place and now become much more expanded. So now in most jobs, most big jobs at least, big company jobs at least, will offer a insurance plan to employees as part of their benefits package. And finally, Medicare Advantage is actually a very popular plan that people have been joining in pretty high rates in the past several years. And it's essentially a combination of Medicare and private insurance. So if you have Medicare, so you're 65 or you're younger and you meet a condition, you get government-sponsored Medicare. So that covers certain services. However, it doesn't cover everything. So if you want more services in addition to what you already have, you can essentially pay an additional premium and buy another insurance plan. And this will be administered through a private company. So like Aetna, Blue Cross, any of those. And the thing is, these plans are very different. So depending on which one you get, there's different services that are covered. However, you can only get it if you have Medicare. So I know that was a very complex explanation, but these are some of the main insurance plans that are offered right now. And these are also important because the candidates are suggesting changes to these various programs. There is also other insurance programs you might hear about, such as the Veterans Association. So the veterans, or the VA covers veterans who have come back from a war, and as well as people who serve in some of the military organizations, such as the National Guard. These are government-owned hospitals and have basically government-contracted doctors who do that care. There's also the Indian Health Service, which covers Native American tribes. And there's various other programs that I don't really have time to get into, but if people have questions, I'm happy to discuss them. So next, I'm going to talk about the big players in healthcare policy. Healthcare represents about 20% of the economy. It's a huge amount of money, and more than many rich countries spend in their entire budget. So because of this, a lot of groups want some kind of say in how this money is spent. So what they do is they hire lobbyists, or they meet with Congress people on Capitol Hill or government bureaucrats, and they suggest ways that they want their policies to be implemented. So these are some of the big groups that do this. The biggest one for doctors is the American Medical Association, or the AMA. They are a lobbying group that essentially, like I said, they meet with Congress, they have meetings pretty frequently throughout the year, and they actually have chapters in pretty much most states, as well as most medical schools. What's interesting about the AMA is that it's actually been losing a lot of influence lately. Back in the 60s or 70s, the AMA represented almost 80 to 90% of doctors. Nowadays, it represents maybe 25% at most. So which is interesting, a lot of doctors have decided the AMA doesn't represent their interests, so they've been moving to other groups. So there's a small group of doctors that still work in the AMA, but despite all this, the AMA is still the most influential group that represents doctors. So doctors who leave the AMA have decided that it's more effective for them to lobby as a specific specialty group. So that's why we have the growth of these various specialty groups. There's the ACP for American College of Physicians representing internal medicine, the AAP, American Academy of Pediatrics. Many of you probably know about the American College of Rheumatology. However, these groups are much smaller because they're limited to people in that specialty. For that reason, the AMA is still more influential because it theoretically represents doctors from many, many specialties. And one of the criticisms of the AMA is that it tends to represent specialties such as surgery or subspecialists like radiology, dermatology, more than primary care groups. However, the AMA acknowledges that this might be a problem in the past and has been trying to improve that. But this is kind of the general debate going on in medicine right now. So third, we have patient advocacy groups, such as the Vasculitis Foundation. So there's many groups that focus on a specific disease, such as vasculitis or lupus or MS or any of these diseases, and they essentially serve as liaisons between patients, physicians, and policymakers. And what really benefit of these groups is that they put a human face on disease. So for vasculitis, you all know it's so rare that many doctors have actually never seen a case of vasculitis in their whole practice. So they might know about vasculitis in a textbook, but they don't really know the human impact or the various parts of your life that are influenced by it. So groups like the Vasculitis Foundation are great for helping doctors and policymakers understand the burden of these autoimmune diseases, and also trying to lobby for efforts to improve care for those patients. So a common example you might see is that there's a lot of research going on in drugs at the National Institutes of Health, or NIH. However, the NIH often gives money to drugs that benefit a large population, such as Alzheimer's disease, cardiovascular disease. It's often harder to get funding for drugs that only help a small group of people, such as vasculitis. But these advocacy groups can do a good job of casting a spotlight on the importance of these diseases, so the government might fund these diseases as well. And finally, we have third-party groups. These are the other groups that have a say in healthcare because their business or their practice is directly dependent on how money is allocated. So these can be insurance companies, hospital lobbying groups, such as the American Hospital Association. They're actually a very influential group. And there's many, many others depending on what aspect of healthcare you have. So really, healthcare is a huge, huge component of the economy. And for this reason, there's so many groups that are involved in advocating. So in some ways, it's great to be involved with this. So the Vasculitis Foundation can be that role, as I mentioned before. But if you're involved with the healthcare system in any way, if you're a nurse, you're a student, you're a doctor, there are many, many ways that you can be involved and you can make your voice heard. So next, I'm going to talk about areas of strength in the US system. I included this slide because people often bash the US system, and for fair reason. There's a lot of challenges, a lot of issues with the US system, and that's why we're doing this seminar, so we can talk about some of the ways that we can improve these things. However, it's important to know what aspects of strength exist right now, because we want to make sure that whatever reforms we make, we're not harming the good aspects of the system. And also to keep in mind that the grass is always greener on the other side. So we look at other countries and see that they have a lot of positives in their system. However, some of the US strengths might not be the same in those other countries. So I just wanted to go through some of these. So first is medical innovation. So as I mentioned, the healthcare is about 1/5 of the US economy. That's a huge amount of money. And that includes many, many aspects aside from just hospital care or drugs. There's innovation, there's new technologies, there's new devices being developed all the time. And part of the reason for that is that we have a very capitalist economic system that privileges people pursuing innovation or new research and development. And essentially, if you can be the first person to discover something, you can get a patent on that and then make a lot of money doing it. So for that reason, a lot of people have incentives to pursue lots and lots of research and innovation. And if you look at other countries, there isn't the same incentive, so there isn't as much research going on. There still might be new drugs or trials being developed, but it's not the same magnitude as the US. Secondly, the US has a lot of specialists. So dermatology, radiology, any of the surgery types, vascular surgery, plastic surgery. There's generally a higher percentage of specialists in the United States compared to other countries. Part of the reason for this is the wide discrepancy in salary. So surgeons and specialists get paid a lot more than primary care doctors in the US. So naturally, more medical students are looking towards subspecialties where they can make more money. The benefit of that is that if you need to see a specialist, in general, your wait time is going to be a lot shorter in the US compared to other countries. So for some specialties like dermatology that I'm going into, there still can be a long wait depending on where you live in the country. However, in most cases, you can see a doctor within a reasonable amount of time for other specialties. In other countries, because of the way that the healthcare system is formatted, it's basically there's no way to cut in line or to get a faster appointment. In the US, basically, you can move to another state, you can drive far away, pay money out of pocket to see a doctor in a short amount of time. The next thing is employment. As I mentioned, 20% of the economy is healthcare. So there's lots of jobs related to healthcare, and not just direct healthcare, also healthcare administration. So hospital administration, people who run clinics, people who work for insurance companies and billing. These are a lot of jobs that are directly related to healthcare. So any changes in the financing of healthcare are going to affect a lot of these people's jobs. So it's important to keep that in mind. One of the drawbacks that I will discuss is that the US tends to have pretty high administrative costs. And the reason for that is we're paying all these mid-level people. So for example, in some countries, there's basically no insurance. The government pays for everything. So then you don't need to hire people to administer that insurance. So you don't have to provide jobs for them. So for that reason, the US tends to have higher administrative costs overall. And as I mentioned, the National Institutes of Health, they do a lot of cutting edge research. And actually, there's been a lot of incentive lately for rare disease research. So vasculitis has been part of that. And many of the people that have been featured in the Vasculitis Foundation have done really innovative cutting edge research. And it's great to see that continue to grow in the future. So the kind of main point of this slide is that the US system does not consider financial costs generally. That's usually a secondary concern. So basically, people in the US have a philosophy that you can get whatever healthcare you can pay for. So whether things are not covered by insurance, if you have lots of money, you can essentially buy that medication. If you can't see a doctor in a reasonable amount of time, you can drive to another state and spend that money and see another doctor. This is all legal, but obviously it's very difficult if you don't have those financial resources. You essentially don't get a lot of healthcare. And that's one of the main challenges of the US system, is how unequal it is. However, as I mentioned, it's important to keep in mind that whatever reforms we make, we want to make sure that we're not messing up a lot of the strengths that are part of the system. So a lot of the policies that are suggested are going to be a balancing act, trying to improve the inequity of the system while also maintaining the strengths of the system. So socialized medicine. I get a lot of questions about this, and a lot of people throw this term around. So I just wanted to clarify what this actually means. So socialized medicine officially is a system in which the government owns all hospitals and pays all doctors. So it's a very narrow type of healthcare. There's not that many countries that have this. The UK is probably the best example. So if you're a doctor in the UK, you are a government employee, and all the hospitals are essentially administered by the federal government. So this is a truly socialized system. The difference is that there are aspects of this model that are applicable in other countries, but they're not truly socialized in the official way. So Canada technically has some aspects of socialized medicine. So Canada essentially has a government that pays for all healthcare services. However, this is really important. The big difference is that hospitals are private and doctors are paid privately by the hospitals. So it might seem like a minor difference, but this actually ends up being a big challenge in terms of reform. In Canada, the government can set rates and charge what they want, but hospitals have to just make do with whatever the government says. In the UK, the government essentially owns all the hospitals, so they have a lot more control on what hospitals are making, what doctors are making. The challenge is that a lot of doctors obviously get paid less in the UK because the government has an incentive to cut costs whenever they can. So there's many countries that have some version of socialized medicine. They might have high taxes and a government that pays for insurance. or they might have government that owns hospitals. But when you hear socialized medicine, it's important to clarify what that actually means. In the US, pretty much none of the candidates are proposing actual socialized medicine. They're usually proposing something similar to what Canada has, where the government pays for healthcare, but the hospitals and doctors are still private. So important to keep that in mind, because you will hear this thrown around a lot. The next thing I'll talk about is that socialized medicine is one model of providing universal coverage for everybody, but there are many hybrid models that include some aspects of socialized medicine, but also other aspects that might not be in the same way. So whenever we are considering reforms, it's possible to look at various models and try to pick the best from those. So for example, one is Germany. Germany essentially has a private insurance market that's heavily regulated. So insurance companies are not allowed to charge exorbitant prices or price gouge patients for treatments, but they still exist. You're still allowed to buy your private insurance if you want it. However, if you're poor or you're not able to buy private insurance, the government will provide it for you. So right now, Germany has this kind of interesting model where they have a capitalist economic system. They have a lot of innovation and research, and they have a solid private market. The difference from the US is that it's heavily regulated. In the US, most insurance companies are for-profit. In Germany, they're non-profit, and that makes a big difference. And secondly, of course, the government does provide insurance for the poor in Germany. In the US, the government does that sometimes, but as I mentioned before, you have to meet certain conditions to qualify for that insurance. Next is Switzerland. Switzerland was interesting because Switzerland was the basis for the Affordable Care Act. So essentially, Switzerland has no government insurance. They're all private companies, and they're all nonprofits. And essentially, people can choose among various private plans and buy whichever one they want. The government won't give you insurance, but it will give you money to buy insurance. The interesting part, though, is that it has a mandate that you have to buy insurance. And with the Affordable Care Act, that was kind of the sticking point. They provided some subsidies to buy insurance, and there were various private companies available, and people were not happy that they were forced to buy insurance because sometimes the insurance wasn't what they were looking for. It's just interesting to me that Switzerland has actually the second highest healthcare cost besides the US. It's a pretty big difference, like per capita, but the US tried to take I think the closest model they could get to, which was Switzerland, and even that didn't really work out in the best way because it didn't really go all the way towards providing insurance to everybody. The third country I'll talk about is Japan. In Japan, it's a lot more straightforward than insurance and reimbursements and all these complicated things we're talking about. Japan has a pretty straightforward system where there's cost sharing. So patients will pay about 25% of costs, and the government pays everything else. There are certain things that are free in Japan and certain things that you pay more than 75%, but on average, this is how the system is paid for. So this was pretty complicated again, but the bottom line I want to say is that when we're looking at ways to reform the US system, we don't have to just go for like socialized medicine or nothing, or be like Canada or be nothing. There's many, many other countries that do a good job providing universal coverage to everybody. And we don't have to limit ourselves to just a few countries. We can look throughout the whole world and choose the best aspects from different places. Okay, so election 2020 health reform plans. This is probably what's been in the news a lot lately, and I'm sure a lot of people have questions about this. So what I tried to do is I tried to group the big plans into these three categories. Every single candidate probably has their own plan and their own nuances and how they're going to pay for everything. But in general, the plans tend to fall in these big categories. So I just wanted to break down the highlights of each of them and then discuss some of the pros and cons. And if you have a specific candidate's plan that you have questions about, it's probably worth just looking at their campaign page and reading it, because I'm not able to go through the details for each single plan. So I'll start with Medicare for All. So this was originally proposed by Bernie Sanders, now supported by Elizabeth Warren. This is basically moving the US to the Canadian model. So as I mentioned before, the Canadian model is where the government essentially pays for all healthcare based on people's taxes. And it administers hospitals in a private way. So private companies administer hospitals and pay doctors. So basically the big change in the US would be that private insurance would no longer exist. And that's kind of the sticking point a lot of critics have against this plan, is that if you get insurance through an employer or through some other way that's not the Medicare system, you essentially will be thrown off of that plan and just given Medicare. And the candidates have different proposals on how they would do that, how they would transition it. But the end result is that essentially every citizen would be covered by Medicare, and we would phase out these other insurance plans. So the kind of benefits of this is that there is a universal plan that works for every citizen. The government would essentially determine the rates, they would determine the administration, so you wouldn't have a lot of these middle people or administrative staff that are figuring out billing and what things are covered. All that would go away. The government would basically set what's covered, people would pay from their taxes, and the government would have a pool of money to use to cover everybody. The challenge is that there'd be some changes in how we do costs. So the only way the government can make this work is to cut payments in some way. The candidates don't want to raise taxes that much. They still have to on some level, but they could tax everybody at 100% and still not be able to pay for everything. So the way they're doing this is they're going to cut payments to hospitals, doctors, and insurance companies. And it's unclear how much they would cut this by. But the side effect of this is that some hospitals and doctors run a very, very thin profit margin. So if they cut the payment by too much, a lot of these players will go out of business. And that's kind of the ongoing challenge, is that a lot of these rural hospitals especially get a lot of benefits from Medicare. So if Medicare starts cutting their rates, a lot of these rural hospitals will have a tough time. Of course, as I mentioned, there's going to be higher taxes. Each candidate has a different plan for how much they're going to raise taxes. But one of the definite benefits of this is that now that there's one insurance plan that covers the entire country, that plan has a lot of negotiating power. So the government could negotiate prices with drug companies and tell them, essentially, this is the fair price for this drug, take it or leave it. And companies will essentially have to follow that. So there will be a lot more wiggle room for negotiating prices. Drug prices will almost definitely come down under this plan. And in general, patients will probably pay less out of pocket because your taxes will be going towards this healthcare plan, and the government will administer it. You won't really be getting insurance through your employer anymore. So this is the Medicare for All plan that is probably the most talked about plan right now in the race. The second thing I'll talk about is the Medicare plus the public option. So this is something that some of the more moderate candidates have suggested. I'll use moderate in quotes because right now it's unclear how many candidates actually support this. But this is usually, if someone doesn't support Medicare for All, they probably support this. So basically this plan is similar in that the government will essentially provide Medicare to more people, but it will still allow private insurance to exist. So if you have insurance through your employer or through some other way, and that you like that plan, you're allowed to keep it. Essentially, if you don't like that or you don't have enough money to buy that plan, you can now buy a government plan called the public option. So what this will do is essentially make the government a competitor against insurance companies in providing insurance coverage. And people will basically get to decide whether they like the government plan or whether they like the private plan. And usually what happens is when people have such a lot of competition, the prices will start to come down. So a lot of candidates are suggesting this is a moderate alternative to the Medicare for All, because you're allowing these private companies to compete against each other and hopefully lower premiums that way. So some of the major cost changes are going to be that you'll probably have a reduction in price just due to the transparency. If I could pay $200 a month for one plan and then $100 a month for another plan, I'm probably going to take the cheaper one as long as the coverage is about the same. And once you know how much those things cost, you can be a more diligent consumer about deciding which things are worth it to you. However, what you have in the system is it's still very fragmented. Under Medicare for All, there's one insurance carrier that covers the entire country. In this plan, you still allow private companies to exist. So you're essentially going to have a tough situation where there's still a lot of fragmentation in the market, and you're not really going to have that leverage in terms of drugs or in terms of prices for services. This plan will probably need some degree of higher taxes to pay for it. Again, the candidates have not agreed on what they would exactly do to raise these taxes, but that was probably what's going to happen with this. And I included this lower drug prices due to regulations or competition. I think theoretically the drug prices will still be lower just because of competition. However, I think they would be even lower under Medicare for All just because of that leverage that the government has. The last thing I'll talk about is a free market alternatives. So the tough thing about this is that this is a kind of an aggregate of many right-wing or libertarian healthcare plans. The Medicare for all and the Medicare plus public option are generally proposed by Democrats. The free market or the plans that I'm going to discuss now are generally proposed by Republicans. I use this in like very broad terms because you're going to get specific people in each party that might disagree. But I tried to combine the main points from a lot of the Republican healthcare plans. So the main kind of goal of this is a behavior change focus. So the Democrat plans generally focus on a government intervention or some kind of drastic change in the overall market to fix how healthcare is paid. In contrast, the Republican plans tend to focus on individual people's behaviors and how that behavior change will affect the overall economy. So the big idea for this is to make health insurance more like car insurance. So think about this. When you have a dent on your car, like someone nicks you when you're driving somewhere, you have like a small dent. When you go to the car dealership, you don't always use your insurance for that. Because if you use your insurance, now you've used the claim, you only have a limited amount of claims in the whole year. Sometimes you say, you know what, I'll just pay out of pocket for this. And because you do that, you have a pretty good idea of how much that costs. So a dent might cost $100 to fix. So I'll just pay that out of pocket. I won't use my insurance for that. And because of this, there's a lot of price transparency, a lot of kind of routine things that get broken or minor damage. You can just pay out of pocket and have that fixed, usually within a couple of days, no problem. And you don't have to fight with your insurance company to get those things covered. So the idea is to make health insurance more like this. So for instance, you would have an insurance plan, but you only use it for really bad catastrophic things. So if for car insurance, you might use your insurance for bad things like a car accident or someone like destroyed your car and you need like the entire thing replaced. So for health insurance, that might be you got a major surgery, you had to be in hospital for a week. These are big kind of catastrophic things that your insurance is designed for. And what will happen is that people will generally use their insurance only for those really catastrophic things and start paying for routine things like medications, primary care visits. All of that will happen out of pocket. And hopefully, similar to how the car insurance market works, people will start to have a general idea for what's like a fair price for those things. Right now, honestly, I have a degree in public policy. I have no idea what's a reasonable price for an x-ray or an urgent care visit or a blood work. I have no idea. But if people start to use out-of-pocket payments for these things, and that becomes a general thing that everybody does, people will start to have a general idea for how much those things are worth. Like I know how much a dent on my car costs because that is something I do pretty frequently. So the general idea is to make health insurance something that you only use in emergencies. And for regular kind of everyday things, we use just out-of-pocket payments. So the big kind of cost changes with this is that you have a much, much reduced role for insurance. So because of that, insurance will only cover really specific things like hospital stays, surgeries, those type of things. So that might mean lower premiums because you're paying less per month to maintain a policy that doesn't cover that much. But on the chance that you do have one of those catastrophic things, the insurance company might make you pay more of that. That's kind of controversial right now. We're not sure exactly how they regulate those things. The other problem is that this is great for someone that doesn't go to the hospital that much. Someone who's pretty healthy, they get their regular checkup, they get medications occasionally. So they pay out of pocket for them, they never use their insurance. And this is the equivalent of someone who's a very safe driver. They never get into accidents, they drive great all the time, they barely ever pay for anything. It does not work for people that are very frequently sick. So people who go to the doctor all the time, people who are hospitalized at random times for various chronic illnesses. The equivalent is someone who might get into a car accident. They might be a very unsafe driver. Not to say it's the same thing, but it's the same way they finance this. Someone essentially who is going to be using insurance a lot of times. It doesn't really make sense for them because they'll be using insurance so much the insurance company will not cover really anything that they do. So I can imagine a lot of people with vasculitis might not really benefit from this kind of plan. If you're seeing 5 or 6 different specialists, being hospitalized for many, many days at a time, it doesn't really make sense for you to have a plan that makes you pay out of pocket so much. However, on the plus side, as I mentioned, you will know how much those things cost because the insurance company will tell you, or people will just know because they do it so frequently. So this is, to me, a pretty interesting alternative because it's such a big change, but it's focusing primarily on how people use insurance rather than how the government administers insurance. If you're interested in these free market alternatives, there's a couple organizations that have proposed like big plans, but so far none of the candidates have really endorsed them. Even the current administration, when they're talking about healthcare, hasn't explicitly talked about any of these ideas. The main idea that this administration has proposed is forcing companies or hospitals to disclose how much things cost. So they're really going forward on that price transparency thing. But right now, there's still some debates on that, so it's kind of an ongoing question how that's going to be implemented. The next thing I'll talk about is this big policy issue that might affect a lot of you, that drug costs are too dang high. And it is true, the United States pays more for medications than any other country by a very, very big margin. And it's very, very clear that there needs to be something done about this. This is one of the few things in Congress that has bipartisan support. Everybody agrees on this. But we have to understand, like, why does this happen? So there's three main reasons I talked about. So the first is the profit incentive. As I mentioned, the US is a very capitalist-focused economy. So any kind of research or innovation, if you're the first person to discover a drug or treatment, you have a patent, nobody else can copy your drug. Now you can charge whatever you want for that drug. And this is why a lot of things tend to cost a lot, at least initially. And then over time, they start to get cheaper as the patent expires, and now other people can compete on that price. However, what the challenge with that is that now there's companies that exploit the patent system. They essentially take a drug that has a patent, the patent is going to expire. So what they do is they change a really small part of the molecule. They maybe add like an extra molecule onto it, and it doesn't change the drug at all. But under government law, now it's a new molecule. They have a new patent on it. So they can extend the patent for another 10 or 8 years. So people keep doing this, and it makes it a huge problem because now nobody can compete on those generic drugs. So one of the kind of problems on the table is that one of the proposals on the table is that the government will force the company to show that their modification is a different drug, or it like significantly improves how the drug works. If it's just a cosmetic change, like, oh, you added an extra molecule that doesn't do anything, you cannot ask for another patent on that drug. Under the current policy, the government is not allowed to regulate drug prices. So essentially, when a company makes a drug, they can choose how much they want it to cost. Insurances will decide how much they want to cover, and usually Medicare is the one that's going to go first. The government insurance will decide how much they want it to be covered, and every other insurance will try to follow that. However, there's no law that they have to cover it a certain amount. So even if they cover, 50% of the cost, but the drug costs $10,000, you're still on the hook for that money. So one of the proposals that candidates are suggesting is that you can let the government regulate prices and see if that brings down prices. And this goes into the third thing I mentioned, which is that companies have a monopoly on drugs most of the time. So insulin is a good example. Insulin was developed a long time ago, maybe 20, 30 years ago. I used insulin as an example because insulin has been a drug that's been around for many, many decades. We know what it does. We know how much it costs. However, the price of it keeps increasing. Doesn't make sense because you'd think that as a drug has been here longer, then it would become cheaper as more people try to make it. The problem is there's only one or two companies that make insulin. So they essentially have engaged in what you call cartel behavior. It's essentially when companies have a monopoly and they discuss with each other how much they want something to cost. So neither company goes lower on price. So if two big companies are like, you know what, we want to make tons of money on insulin, let's just agree that we're not going to make insulin less than $250. So even if they could theoretically make money making it less than that, they decide as an agreement to keep the price high. And this is a big problem in the drug industry right now. It becomes even more challenging when the drugs are really costly to make. Because if your drug needs a huge investment of money, these small startups are not going to be able to do it. You have to rely on these big companies, and they can just, 3 or 4 of them can make the entire market. So I included a few solutions for this. So the first solution is to import drugs from another country. So we border Canada. We have good trade relations with Europe. They would be pretty straightforward to buy drugs and just bring them across the border. And actually, one of the candidates did an experiment where he drove people across the border into Canada, brought drugs, brought them back, and they saved an insane amount of money doing this. This is actually a pretty good solution, and I personally think this is a very good idea. The real challenge is that drug companies are fighting this all the time because essentially they use the US market to make all their money so they can take losses in every other country. If we start to use drugs from other countries, drug companies will take a huge financial hit on that. So they're fighting this all the time. So if you want this policy passed, definitely talk to your congressperson or whoever represents you and try to get this passed, because I think personally this would be a great policy for everybody. The second challenge is that you could promote more competition and generic drugs. This is already happening, as I mentioned. For example, you've seen Tylenol or Advil. These are actually brand name drugs. If you go to CVS or Walgreens, you can find acetaminophen, which is the generic form of Tylenol, or ibuprofen, which is the generic form of Advil, and they're usually way cheaper than the brand name drug. In terms of efficacious, like how effective they are, they're about the same. So patients already know that you can get some of these common drugs at a cheaper price. The problem is it doesn't work for drugs that are really rare. So a lot of vasculitis patients are on complex medications like mycophenolate mofetil or rituximab. These are really complex medications, and companies need to invest millions of dollars in developing them. So you can't have Walgreens making rituximab, for example. It's not going to happen. So if only one company or two companies make that medication, they can charge whatever they want. And third, as I mentioned, the government could regulate prices. So the government could say the price of this drug is X, and everybody has to follow that. The challenge is that it's really hard to say what's a fair price for any drug. Drug companies say, well, we invested $3 billion making this, and if you sell it for $10, we're going to lose all our money, and then we'll go out of business. However, if the government sets the price too high, drug companies are like, okay, that's great. Now we don't have to sell it for less than that. So it's a really tough challenge to figure out how much is a fair price for a drug. I personally think this is actually something the government could do. They would just use another country's index for what's a fair price. So we could say, we're going to use Canada's prices and just set that as the fair price. So that's one potential solution. The third policy I want to talk about is a doctor shortage. So by 2030, there's an estimate that there's going to be a huge, huge shortage of primary care and general practitioners in the tens of thousands. It's an estimate, but everyone pretty much agrees that this is a huge crisis. And it's especially worse in rural areas. It's unfortunate, but a lot of medical students, even if they train in a rural area, they're much more likely to move to a city than to stay in that rural area. So really, the challenge is that there's not enough job openings for graduating medical students. This doesn't really make sense because we've been seeing lots of medical schools being constructed each year. There's always new schools coming up. But the reason that there's still a doctor shortage is that Congress has actually restricted the doctor supply. When you finish medical school, you have to go through residency to become licensed. So it doesn't matter how many medical graduates you produce, the number of residency spots has been actually the same since about 2000. So in the past 20 years, the number of residency spots has not changed. So what ends up happening is that you have a lot of people that finish medical school, they are a doctor, but they are not able to get licensed, so they can't practice. And you have a lot of these students that are studying for 2 or 3 years, trying multiple times to get a job, and sometimes they can't do it. It's a real waste of talent. To get into medical school is very difficult. And if you manage to graduate medical school, that's even more difficult. And now you have all these students that essentially can't practice because there are not enough job openings. And it's a real challenge, and a lot of times Congress hasn't really been able to fix that. So what do we do about this? So the really important thing to do is to lobby Congress to increase the doctor supply. Please do this, as medical students of all stripes, especially those who cannot get a residency in the first round, they will absolutely love you for this. Really, the more openings that exist, students will go towards them, and there will be at least some progress made towards fixing this doctor shortage. It doesn't fully address the shortage in rural communities, because right now a lot of the rural spots are still unfilled. Students really just don't want to go there. But if you are able to increase the number of supply, there would definitely be more students willing to go to rural areas. The next solution is to allow mid-level practitioners, such as nurses, physician assistants, others, to practice in their own way. That's a good idea in rural areas, especially if there's no doctors around for many miles. A nurse or physician assistant can handle a lot of the straightforward complaints that you see. The challenge is that we also have a nurse and a PA shortage. So even if you fix like the doctor shortage by allowing mid-levels to practice, you're going to create a shortage in another field. So really, and unfortunately, a lot of the conditions that patients with vasculitis might have, you really need someone who's very trained in complex medicine, and you will need an actual doctor to see a lot of those complaints. So having mid-level practitioners is a good idea in the short term, but it's not a long-term solution for a lot of these complex challenges. So lastly, I'm going to just talk about how you can get involved. So number one is vote. Vote, vote, vote. The election is coming up next year. Obviously the presidential race, but there's Congress races, there's your school board, there's like local races. Please get involved, learn about what your candidates stand for, meet with them, talk to them, and then obviously use your right and vote for them if you agree with them. Really, a lot of these representatives don't know about the issues that face everyday people. Especially if you have a rare disease like vasculitis, they might have never seen someone with that. So really letting them know what challenges you have and how their policy could make that easier, that's really important. And it might affect how they vote in the future. In terms of local level, definitely go to town halls, meet your local representatives. For the state level, you can call or mail your senator or representative. I've actually have a couple of friends that work for state and federal senators, and they say calls are much, much more effective. You can email them or mail them, but usually they just delete those mails, or they like send a response that's like a straight, like a template. But if you call them and actually talk to a human being, that actually has a huge impact on what they do. And next is advocacy days. That's what I mentioned before, but a lot of these societies, such as the American College of Rheumatology, American College of Physicians, they have designated days where they meet with Congress and talk about issues that affect their specialty. So I think it's very important that you try to get involved with these whenever possible. That's probably the most direct contact you're going to get with these lawmakers. And obviously at the federal level, all of the above, it's obviously harder to get in touch with them, but still, they're responsive to their voters' concerns. So if you make your voice heard, there's a good chance that they'll follow it. And the other thing is to do your own reading. I noticed this, especially nowadays, there's all these different narratives and it's hard to get an objective presentation of facts. Usually people come in with their own agenda, or they don't actually present everything because they want to make a candidate look bad or look good. So I always say, do your own reading, go through like objective third parties, sources. So for a lot of this presentation, I use the Commonwealth Fund. It's a website online. They publish research related to health policy. And they have a very interesting tool where you can click on a country and they'll give you a really brief overview of how that country does healthcare. So a lot of the stuff I talked about at the beginning about the different countries, I got that from this website. Second is Health Affairs Magazine. This is a health policy publication a lot of doctors like to write in, and it just discusses ongoing issues in healthcare and some of the current topics of conversation. Third is PubMed. So this is the international database for medical research. If you publish a paper in any major journal, it'll probably be on PubMed. It's designed for any part of medicine, but you can also find health policy articles in that. And finally is UpToDate. This is more clinical. It's for specifically medical problems, how to treat diseases. When doctors are looking up medications or how to treat certain things, this is the main resource that we use. I've used this personally many, many times in residency, and it's a very good resource. However, it's written for a doctor audience, so it might not be as relevant to patients. So I just want to thank the Vasculitis Foundation, especially the Kansas City chapter. I did my first part of this presentation at that chapter meeting and got some great feedback. Allison, Joyce, Ed, Young Adults Group, and my mentor, Dr. Dua, who got me interested in this topics. Thank you very much. And I'm happy to answer any question that you might have.
Well, thank you, Aamir. That was very insightful, and you made what could be a very painful, long, hard to understand subject into something that was really down to the level of most of us. to understand this subject. So I do have a few questions. I've been checking social media, and I have we've gotten some questions in from some of the folks in the vasculitis community. So I'm going to throw some of these to you. And this question is a fairly high-level one, but it's asking, what is the state of affordable care right now, the Affordable Care Plan, the policy? Because we're getting bombarded with all these potential options. Can you kind of encapsulate where things stand now since the last administration?
Yeah, that's a great question. And I definitely myself have had a tough time following all the changes in the policy. I think right now the big kind of policy implications are that there still is a private insurance market where you can look online and buy insurance. You can buy insurance through private companies. So this current administration has had just a different approach to enforcing some of those rules. However, a lot of the rules are basically here to stay or not going to change. So for example, there's one area that says people can stay on their parents' insurance until they're 26. That is still in effect. There's a law that says you cannot deny people coverage based on pre-existing conditions. And as of right now, that law is still in effect. And also, there are certain regulations on hospitals. So they have to use certain electronic records. They have to report certain quality metrics to the federal government in an effort to bring down costs and improve value. And as of right now, even if the government doesn't enforce them as much, hospitals have basically decided that we think this is important, we're going to keep doing this. The main thing that has changed under this new administration is that there's no longer a penalty for not buying insurance. So under the Affordable Care Act, you were essentially forced to buy one of the private plans available. Even if you chose not to do that, you would basically be penalized for that. Under this administration, there's essentially no penalty for having no insurance.
What are some of the challenges and frustrations that doctors are having that may make them want to retire, leave the profession, or not become a doctor in the first place?
And it's hard to make a single statement because there's so many factors at play. But I can talk about a few of them. One of the big challenges right now is burnout. So a lot of doctors, as you mentioned, are retiring early, leaving practice for something else, and they cite many different reasons for that. One of the reasons is that they feel a loss of autonomy. So because of regulations or the fact that a lot of private practices are being bought up by these big hospital systems, doctors many times feel that they don't have autonomy over their own decisions. And they would rather practice independently or not practice medicine at all if they don't have authority over those things. Another challenge is that, as I talked about, the healthcare system is so unequal. It's very drastic in certain places. So a lot of doctors are really frustrated that they can provide the best care medically that they can give for a patient, but all these things outside their control, like the patient's insurance status, their income, their education level, all of these other factors are going to make them have horrible health outcomes. So many doctors, and myself included, have chosen to focus on policy as a way to fix some of those problems, but a lot of doctors are just so frustrated they leave medicine. Another challenge, kind of ongoing challenge, is the electronic health records. A lot of doctors have said that the biggest challenge at work is the amount of administrative work they have to do. So like putting in orders, writing notes, all this documentation. And the medical societies have definitely found an association, like more paperwork equals more burnout. So the challenge right now is trying to reduce the amount of paperwork that doctors do and give them more autonomy over their decisions so fewer of them want to retire. The other thing I'll talk about is medical school is very expensive. So the average tuition for a medical school is probably more than the college, so probably in the order of like $60,000 a year. With financial aid, that's still less, but it's a very big hurdle because think about it, you have to do 4 years of college, 4 years of medical school, minimum 3 years of residency, sometimes more than that. And you're essentially earning money much, much later in life than other people who just went to college or just went out of high school to get a job. So a lot of people have a tough time delaying income for that amount of time. So really the challenge now is either reducing medical tuition, which some schools have done, letting doctors finish training in a shorter amount of time, which is also happening, or, and this is kind of goes back to what I talked about before, if any candidate proposes cutting salaries for doctors, this is why a lot of doctors get worried. I mean, they make salary that's pretty high later in life when they're like 30 or 40 years old. But when you have, $500,000 worth of loans to pay off, you really need a pretty high salary to pay that off. So any cuts to salaries are making doctors very afraid.
What are some of the challenges that patients with rare diseases, and specifically patients with vasculitis, what are they facing and dealing with in obtaining insurance and keeping their insurance as they try to manage their illness?
Yeah, that's a great question as well. It's hard to say about specific people, but some general things I've heard about are that first, people are just not clear on what vasculitis is, and this is a challenge because it's so rare. A lot of doctors have never seen a case of it. A lot of insurances just don't know what conditions might be related to vasculitis or what might be their independent problem. So there might be things that are not covered. Certain medications are, for example, there's not that many trials about vasculitis drugs because it's hard to recruit patients to be in those trials. So a lot of doctors will prescribe medications that are used for another disease. So for example, they might use a medication used for lupus or for MS as a trial for vasculitis because they theorize that it might work. But the problem is a lot of insurance companies tend to use like academic studies as a way to validate whether they cover anything. So it becomes a very big challenge for doctors because they're trying to make sure patients get the treatment that they deserve. But the insurance company basically says, we have no evidence that this works, so why does it work? That doctor has to then argue for it. It's like a back and forth. So really it comes down to the fact that there's not that much evidence about what works for vasculitis. So when you're going based fully on like academic studies, insurance companies will give you a tough time covering a lot of things.
I see. Okay. You had talked about in the presentation about getting medications, drugs from other countries as a way to reduce costs. Now, how would a drug like rituximab fit into that? Is that something, a drug that would be, easily adaptable to that? Or would there be others that, are more so than others?
Yeah, that's a
right.
good question.
You know what I mean. Sorry.
When people suggest this policy, it's mainly for common drugs that we use all the time. So they like drugs for diabetes, high blood pressure, high cholesterol, things that a lot of patients take. Because we have a lot of evidence for how safe they are, what the side effects are, all these things. The challenge with these biologics or more like complicated medications is that you have to be very clear on how they're made, what facility, if they're regulated. And that's actually hard enough in the US. One of the things I've been looking at is pharmacies, and like there's certain pharmacies that can dispense certain drugs. But a lot of pharmacies are not allowed to dispense certain drugs because they don't meet the minimum safety requirements. So if you start going to other countries, and you need to be very clear on the safety regulations and what they're using to make these drugs, because drugs like rituximab are dangerous if not handled properly. So it can become a big challenge. So I do think that some of these complex medications probably won't be able to be brought in from other countries.
Mm-hmm. Okay. So it's sort of an issue of oversight and quality regulation, that type of thing.
Right. The drug is just so complicated to make and so unstable that you need to have a lot of confidence in the facility that's making it.
Okay.
Okay. Aamir, thank you very much for leading today's webinar. As we said, it's a topic that is probably going to take more than one webinar to really convey all the information that people need to know about the healthcare policy. So thank you, and we look forward to talking to you again at some point. Take care.